very easy to even create an infrastructure if not there and buy a machine. I don't think the ECMO machine is expensive, but the expertise, the dedicated team to monitor and keep on. These are all still a big way to go. These are all logistical challenges which we face day in and out. All this is done. You have machine, you have logistic, you have expertise. What other things are having a problem? There are 30 family members from different part of the city are available on the outside. Whenever this kind of cases comes, I think we had a situation in one of our exams institute where a medical professional was involved. There were hundreds of people who are waiting outside to see ECMO being successful. So the same thing happens to many of our hospitals in Yashoda. When somebody is so sick, a VIP, a young patient, a potentially influential family, you will see a good huge amount of attendants waiting with some expectations. So a huge amount of all this expertise takes into account of counseling, convincing them, telling about all this which you learned. What are the options? What we are going to do? What will be the outcome? What these patients are all very sick and extremely high risk group. Any small, as somebody was saying, a cannula may not give few seconds. A clog may not give few seconds. An infection will terminally knock out your patient. Any small thing, the smallest mistake can knock you off you. To bring those aspects which are not technical, not expertise, but adding to that angle, we will take the list of other things to invite. So we have a list of panelists who are expert in those different fields. So we have Dr. Ravikant, who is a city anesthesiologist. Is Dr. Ravikant reached here? Okay, yet to come. So we have Dr. Vijay Kumar sir. Dr. Gopi Krishna will join us for the admin side. Sir, please join us. Dr. Gopi Krishna is our senior vice president. And we have a different bonding of love that happened in Care Banjara, where we were actually traveling together for 6-7 years, and this is experienced by Misra and me, where a mob is there in front of you. He will be coming to rescue all of us, to talk to the families. So he will share his experiences. Then we will request Dr. Vinith, who are the department head of emergency medicine. Where is the first entry point of that? Our senior cardiology colleague, Dr. Sasikant sir, is he available? Yes. So he will add his wisdom. Sir, we don't need ECMO, we need your wisdom. So he will add his wisdom to it, because he has a very high sense of humor. So he will. So this is a breaking session for all of you. It will be an entertaining breaking session. There is no science involved in this. This is all about how do we manage. And we have Dr. Vivek Gupta, who has been an expert. So we will use him to know different Indian context, how we make things differently. We will request Dr. Preeti, who is an interventional pulmonologist doing a lot of procedures. There is a new indication. As we see, NIV HFNC is a new indication to intubate a patient. When I was a student, it was not an indication to intubate a patient, NIV or a HFNC. Now we are talking about HFNC being an intubation. So they are using ECMO as an indication to do procedures of airway, where they have to balance both of them for a few hours and decannulate. And we cannot miss Oja sir, who has been here, who has been a long. So with this we need surgeon's perspective. So we will request Balsubramanya sir, who is our thoracic surgeon, who will add his angle of expertise. So to initiate the discussion, so Dr. Bhavindram, yes. So there is a new angle to Bhavindram I wanted to mention about him. So many of us were talking about intensivist or a critical care specialist and a vascular surgeon or a surgeon who can actually do the intervention. So we were talking about a vascular team who actually does the cannulations help. So we wanted Dr. Bhavindram sir's help here. So to take the questions starting, I will start with Vivek sir. Sir, Can we have mics, please? So, we will not go into any science, sir, because we all understand the science has been a lot of overloaded for the last couple of days. So we'll go out of science to make them little break of continuous learning before they go into the station. Whenever a call comes to you that a patient needs ECMO, what are the things comes to your mind?
Usually it's I work in a cardiac center, so most of the call comes from our own medical college, from the emergency department for a patient who is crashing. So the things which I start thinking the moment I get a call, depends upon which call I have. It's a respiratory ECMO or V ECMO. V ECMO, most of the time we get a call for aluminum phosphide poison. So these patients are really a crashing or almost crashed patient who have probably a ventricular tachycardia, their unrecordable blood pressure on high vasopressors. So the first thing I always ask when I get a call that there is an aluminum phosphide poisoning patient. What's the condition of the patient? The first question I ask from the resident. So he's 90% time he is hemodynamically unstable on high vasopressors. Okay, what about ABG, blood gases, and lactate levels? And third thing I ask, echocardiography finding. What is the echo we have done or we have not done yet? So we quickly mobilize echocardiography to plan for it. And next question I always ask, have you spoken to the relative? So plus minus, because gradually our own people are learning, so they.
It's a public unit or it's a private company?
Private.
But it's cost effective, public, trust based. So he spoke to us, but he spoke to us about how much time he has, how sick the patient is, the family available and ready. But this is from a clinician's perspective. We will switch the question for an administrative perspective. Suppose Dr. Gopikrishna, you get a call that one of your hospital patient needs a ECMO. So what are the things which will come to your mind? I am not talking about the indication, science and all, that's all discussed. What are the things which an administrator will be a nightmare to get a call? 1 o'clock you get a call, we need a ECMO.
Definitely first point comes to us, family, understandable, the socio-economic status of the family. Then usually ask who are available for patient, attenders, how close they are. Then emergency room itself, audio video counselings. Then other logistics, availability of surgeons, how we store 2-3 oxygenators and circuits, being a big setup like Hyderabad unit. So first is socio-economic status. We need to understand not superficially, in a significant manner. It's not about start, they pay 2 lakhs, 3 lakhs, then we start, then after 24 hours, some other family members come and they meet us, they want to take patient Lama. So we have faced these situations. So ECMO is completely different compared to any other clinical situation or surgery, including transplant. For example, liver transplant, we cannot compare with this ECMO. ECMO is completely different scenario for administration.
As an administrator, you will love to get a call that your patient had a ECMO because it's a double-edged.
Yeah.
You say it creates money to you or revenue to you. The other side, you say there is a collateral. So how is the feeling, the mixed feeling you have?
Now, when we started 2014, maybe in other setup, now ECMO counselings, now everything become easy for us.
So he spoke to you that whenever such call comes, the first thing comes to him is, he may be politically answered in a different way. He said a very responsible legal attender availability. And then he said, I will also look at the socio-economic status of the family and finances. Okay. So many of us, believe me, we have situations where a patient is available and we know this patient may be ideal, suitable candidate probably needing some form of extracorporeal support like a VA ECMO or a VV ECMO. But many of us don't look at the other side. What is the socioeconomic status of the patient? Even though they say we have enough money, this is the situation I faced in the last 10-15 years. I have enough money, do whatever you want to do. And then you realize, I asked, so okay, let us go ahead. The family is very willing, they wanted everything to be done. This comes from an emotional mother who just wanted to save 18 years or a 20 years or a 30 years son, or a wife who is a newly married wife who wants to save her husband. But when we actually deeply go into the inquiry, when you inform them regarding this, the inquiry, we have 3 lakhs money. You don't worry, you do whatever you think, I can manage this all. See, for them, that amount is huge. It's not for you when you ask about ECMO. So the translation of what you are going to do and how much time it is going to take and what will be its implication on the outcome also makes an important contribution. So as an administrators, we always think, okay, a ECMO case comes, there will be additional revenue. With additional revenue, there will be additional responsibility, additional complications which will come out. And that will be one of the biggest challenge. As any of you who are residents here, consultants here, or many of you may be also practicing ECMO, these may also equally play. So many times we shout and scream at them, including me. You don't even understand my patient's seriousness and acuity. You sitting there, how do you understand my situation? We need this patient to be put onto an ECMO. And that need to be done now, right now. And we have our team sitting here, what are you talking about? Money and all is your problem, not my problem. And this is some of the times where we don't stand by them, and this may create a complexity later on the next day. So Vinith, it's very easy to talk about creating all these teams of ECMO teams or ECPR teams. ECPR is when a viable, reversible patient gets a witnessed cardiac arrest or arrest within a limit where you think the all vital organs are intact, you can actually create a ECPR in them. But I will not go into the theoretical aspect of it, how do we do a ECPR, but I will ask all of you, maybe theoretically looks very possible, but a patient who was brought from some community, from a road or from somewhere, and you are there, and you know the patient is young, viable, very active. What will be your challenges when you actually come across a ECPR in there?
So I will finish last point around. So many postgraduates and young doctors are there. So in other words, as per my experience and wisdom, ECMO, when you choose the patient, you have to be very wise in terms of first clinically, socially, financially, and keeping in mind hospital reputation also. So in other words, ECMO, we cannot just like that advise for each and everyone, keeping in mind Indian socio-economic status. Thank you.
As Sarah has told, like the patient runs into your ED, he crashes down. It's an young patient where you can do ECMO. It's viable patient, but the attenders who brought the patient is important first scenario. After counseling, initially in that rush and all, they will agree for everything. But after putting on ECMO, they may not be able to continue the treatment. First part. Second part. Initially, when you get prepared, they'll say yes. When you are ready with lines and all, your team is here, when you are planning to initiate ECMO, you may have a cardiac arrest again. They may blame you that this part of the thing is like, it takes at least an hour for getting logistic things done. Vascular surgeon should be there, intensivist should be there, respiratory therapist, everything in place. It takes at least 40 minutes to 60 minutes for me. So once if the team is here, in the meanwhile, if the patient had a cardiac arrest and expires, it will be very tough for us to explain them. I have asked you to do everything, why didn't you do? This 40 minutes or 60 minutes, you wasted the time. If you had done this earlier, the patient would have survived. This is one part of the story. And initially, after immediately keeping on ECMO, if we had an arrest, that will be a big ruckus. It will be tough for us. And in between, there will be some other person who comes with a half medical knowledge. He turns up and asks you like, why did you do all this? When the patient, you are only telling that patient had a cardiac arrest, no chances of survival. You'll only explain that. And again, how can you make all these things? It's so expensive for them to bear. Patient is gone and you have done all these things. What's the point in doing this? So that becomes a big issue.
Assuming a very sensible family around, for example, I am there, I say, I understand everything, I understand all these things. I am a well-informed, educated clinician or some known clinician's family. And I tell, you go ahead. I am ready with my money, I am ready with my consent, I am ready with my all information. In real time, you now have a patient who has an indication, will not go to. What will be a challenge to bring the team onto board? So it is in the middle of the night, 2 o'clock, and you are at home. Some of your consultant will be on board. The challenge, you said 1 hour, it's too optimistic. I doubt myself. In the best of the centers in the US where there is a cold ECMO or ECPR team with in-house team, they may take a half an hour to hour time to actually talk about it without even implication of all this which we are talking about. So what will be a challenge there?
Like as you said, sir, it takes 1 hour is the time. What I said was like initially when we identify the patient, immediately if we announce a code for ECMO, what we are planning earlier, if we initiate that, in the meanwhile the team will come. In the meanwhile, we'll have a preliminary counseling with the family members, and this takes around half an hour to 40 minutes. And immediately when the team comes, so we can talk.
Team, what is the thing which comes to your mind? Assuming every hospital has little variability.
It's very tough actually to get the team itself. Is
So who are the team?
Vascular surgeon,
Okay.
who places the cannula, and an
This is a new addition. We should appreciate Dr. Bhavin Ram's all efforts so that he came onto the board to emergency department. Okay, so congratulations. See, you are the first man to be called. Okay.
Then the intensivist who has to take a call, and the physician, and there is other part of the story where it runs like, I know some doctor over here, I came for the doctor. First I have to convince that consultant.
That is the primary admission.
Yeah.
They were on board.
That part has to be
Initiating to ECMO, one is you said vascular surgeon. Okay, agreed. Anybody else?
Intensivist.
Okay, why intensivist?
To settings and all.
To continue the care.
Further continuum of care will be under them.
Okay.
They have to be involved. And other part, respiratory therapists and all. The one who handles the cannulas.
Perfusionist.
Sorry.
Perfusionist.
Yeah, perfusionist and all. And the one who handles the cannula, the technicians who handle the machines and all.
So probably a vascular team if you are on board or a CT team on board. So assuming ki Bhavin Ram sir is not here or a surgeon is not here, what is the standard time if you call in the middle of the night, 2 o'clock, asking them to reach here for a vascular cannulation?
An hour minimum. Minimum an hour.
So
I'll add to that, if I can have a mic.
Yes,
Just
yes.
give you one practical scenario only, and how it works. Sorry to interrupt you, Dr. Venkat, but again, just I'll give you one live example. I think 3 months prior we had a call, because now we are having a ECMO team kind of a thing. We have started that part and we are working very efficiently. You can say last 4 months,
True.
it is going on very well. So what happens, there was one patient coming from outside. They were coming for ECMO only. I got a call at 4 p.m. So one patient is coming, young patient, I think some poisoning or something was there, who requires a arterial ECMO. Okay, we know venous, we know that, okay, it's easier part. We know arterial is little bit difficult. 4 o'clock got a call, okay, I'm here only till 5:30, I'll be in hospital, so not an issue. It is reaching only. Patient reached here by 4:30 from our other district. Now, that circus part or whatever, sorry for that word, but again, that starts. One is primary team person, where to admit. Second thing, convincing the patient, because from the disciplines they will say that no, ECMO is a lifesaver, so you go and do it. But they will not tell about all the practical aspect of what Dr. Gopi already told us about finances, and then convincing them and then telling them that how long it will go on. We know arterial, okay, you can say it is 3 days or 4 days maximum it will be, but again that implicates about the finances. I waited till 5:30. I gave a call to the person who had called me that what is happening. Sir, sorry, still patient is here, but we have not come on board for everything. I went home. Now, after reaching home, because I stay in Kukatpalli, evening time 5:30 I left, so I reached at 6:15. 7:30 I got a call. Sir, we are ready. Now primary consultant is also ready. He has agreed for ECMO. Okay, and relatives and everything is fine. So I came here. I think 7:20 or 7:30 I started. By 8 I was here, and by 8:30 ECMO was inserted and patient was fine. At that time I think I remember Shashi or sir was there, and by 8:30 it was done. So practically what should be done is, like, if patient comes, when we are doing sorting down financial and logistic issues, we give a call or message to the team members. And if you are taking 45 minutes of time of explaining and arranging the financial clearance, I think in Hyderabad that is a luxury, that in 45 minutes time anybody can reach to the hospital from any part of the city. And if it is night, definitely it is not more than 30 minutes time. And that time we should be utilizing for arranging the things.
I will interrupt, sir, for just to make things more interesting. Vineet has called you to reach here in 45 minutes in the middle of the night, and he started counseling. After reaching to the emergency room, he tells you, sir, we counseled, we failed to convince them, now you have to go back home.
So, Dr. Venkat, I'll tell you one more thing. Vinith is familiar with that, and as a vascular surgeon, I am familiar to that, because
So we have a very compliant, very soft surgeon. But I hope real time it will
No, it is soft on the stage. For Vinith, it will be difficult at midnight. Okay, so this is on stage now.
It's very much acceptable if we go back home again.
This need to be in the mindsets of every clinician who are on board. So just to give you an overview, over a time, if you see the western part of the world, which we will go to Dr. Vivek and Dr. Oja, we have a ECMO referral centers. Okay, not all institutions and all hospitals like what we do in Indian context may have a ECMO services. They are all been NHS or NIH driven services, where ECMO has ECMO cases all been referred to as centers, where are ECMO centers, and those centers will have a full-fledged ECMO teams available 24/7 on board continuously most of the time. So they groomed up that. But I think in Indian context, we don't, suppose, assuming any of our hospitals, we don't have that volume to have all the team 24 hours sitting and waiting for an ECMO case. But over a time, if one of, suppose, we assuming, sir, if 4 of our units, in one unit, if we create an ECMO center, maybe that's a possible, that team can run around to wherever it is required and can execute that. So taking it forward, sir, Dr. Vivek, you wanted to make a point.
Yeah. Sir, this everybody was discussing that there is always a problem while counseling these patients. There are several reasons for it. Besides cost, if you look at uncertainty about the outcome,
True.
that's absolutely important.
True seriousness and uncertainty.
Yeah, and second, it is not a treatment. In any respect, it's all just a supportive therapy. So you can't answer this question that when my patient will be fine. So these are the challenges when we see. These are the challenges we come across. When the patient will be fine, no one knows. Any complication when you talk that there can be ICH, there can be this, there can be that, then there will be 1,000 questions. And if you don't tell at this point of time in the beginning when a patient is attendant is listening at this point of time, they will never listen from day 2. It is the day 1 of ECMO or day 0 of ECMO when you start. Before that, if you counsel and if you talk to the relatives, they will listen. Otherwise, from next day, you will be on the receiving end that they are asking every question. We have deposited 50,000. What happened to my patient? This kind of a conversation actually happens. It's a very common conversation.
Okay. In the recent years, if you see, Dr. Misra was and Dr. Charan was also adding, the sepsis has been added as an indication. Earlier time we were saying sepsis was not an indication. It's too sick patients, infected, organ failures and all. Over the last decade and so, we are getting more and more information. If you have a septic patient and have a shock more related to your cardiac issues, like the patient had a septic cardiomyopathy, you have a bad LV or RV dysfunction because of your sepsis induced cardiac dysfunction, those are the subgroup of population or the subset of patients in septic group also may get benefited, and this has been more so happened in the pediatric, extrapolated to the adult. So looking at that as an indication in a VA ECMO, in my short experience, what I realized is if you have a reversible cardiac cause, a VT VF arrest, recently we had an experience that somebody for an infertility was getting an ovarian stimulation, and we don't know in OT had a sudden cardiac arrest. And there was a lot of continuous CPR done. The lady kept on arresting on the way, reached to our emergency room a few months back. And in the ER, there was a continuous CPR going on with adrenaline pushes. That lady is getting pulse in between, hardly to the carotid, no recorded blood pressures. Arterial line is also not able to secure. And in these cases, there was an ECMO initiated because the family was well informed, and Dr. Ravikant was also involved in those cases. And in 24 hours, this patient's myocardium, which was stunned probably because of that CPR and that anaphylaxis, we have contemplating retrospectively whether it is an anaphylaxis, whether it is some myocardial stunning, what happened exactly during that intra-procedural period, none of us could guess, but that lady was in close to a death scenario. In 24 hours time, the patient's hemodynamic stabilized, the patient is absolutely conscious, and within 36 hours we started removing, weaning, and the patient discharged in third or fourth day. Why I am giving this scenario? These patients are otherwise completely healthy, not like septic or ARDS with lot of cytokines, chemokines. They had a sudden myocardial some kind of insult in the form of a massive MI or a myocarditis or some of them. If you give a support to them, we are now seeing the recovery rates in those cases where there is a reversibility is phenomenal. They quickly turn the table around. In this context, I just wanted to learn, because 10 years back, when we were students, when any patient comes in cardiogenic shock to my emergency room, there will, if you are a PCI center, you will be quickly wheeled down to a PCI center with vasopressors. And if the patient is too unstable, you also initiate a IABP in the emergency room and wheel this patient. And I have seen some of these patients will also be an automated lateral CPR machine connected. The patient will keep on arresting, you will be doing CPR in the lifts and also in the cath lab, and parallelly the PCI will be going on, and you stent them and try to revive them. In this context, what is the role right now when if you have an ECMO stations of using a VA ECMO if some family is affordable? We'll dump that affordability to Dr. Gopi Krishna.
Thank you, Dr. Venkat. Nice talking to you all here. It's really exciting. I should have been here from since morning, but 2 examples, 3 statements is what I would like to say. Yes, it's a wonderful way of approaching this patient who has crashed in the emergency room or just outside the hospital. CPR is on, and we don't have a rhythm, we don't have a pulse, or it's miserably low. In that situation, an IVP is not going to help. It's only CPR, and a quick ECMO would make a world of a difference. And we did have many patients who have recovered with that. Having said this, there's a lot of denial, resistance, and apprehension and fear from the attender's point of view, which we have to address much more, like what Dr. That is the most important thing. The first example for me is an orthopedic surgeon working in Usmania's father had an MI in Warangal. I'll take 3 to 5 minutes. Is it okay?
Yeah.
So it's the practical things which are important. The patient had an MI at Warangal. He's a very senior physician, sees about 100 patients a day at Warangal. He had an MI, he was thrombolized, he was shifted to Hyderabad. The cardiologist spoke to me and said, we are shifting him, he's stable, please take care. Somewhere near Uppal or Tarnaka, he had a VTVF. So the boy in the ambulance started the CPR and told the driver, step on the pedal, reach fast. We are having a CPR. It suddenly came in out of the blue because post-thrombolysis, VTVF is quite common. Reperfusion, everything is quite common. By itself, the myocardium is irritable, and even if the vessel is occluded, they can have a VTVF. The ambulance driver stepped on the pedal. The siren burnt out somewhere near Tarnaka. So that signal, what you get going, that went off. So what happened? He said, I'm driving fast. The signal is not functioning now. I said, okay, step on the horn. So he stepped on the horn, kept honking, reached somewhere near the second event, and the horn burnt out. So they didn't have a signal. They were driving the ambulance. They came in fast, and the orthopedic surgeon reached from Usmania here. We brought in blue, cold, occasional complex coming in. Now that is the patient. He just has one QRS complex per screen. We pumped on him, got the CPR, did a CPR, gave a ton of adrenaline. We started having 2 or 3 beats on screen for the cardiac complexes. no contraction on the CPR or the echo.
Pulseless electrical activity.
Absolutely. We have occasional ones. We did a CPR and we said, okay, he's really in a very, very bad condition. The only chance we have is take him to the cath lab and try to open the vessel, which is the culprit. The orthopedic surgeon said, look, I've seen dozens of such cases. There's no point in continuing CPR. I think you guys should stop doing the CPR. He said, boss, this is something, doctor telling this, doctor, orthopedic surgeon telling this. He said, okay, fine, let's continue the CPR. CPR is being continued. Behind the screen we were talking. And after another 5 minutes, we said, okay, we got 3 or 4 complexes. We still have a chance. The boy in the ambulance said, sir, I've never stopped the CPR. CPR has been continued. And we can do a good job. He was very confident that I didn't interrupt the CPR again for 5 seconds. That was the good thing. So we said, we still have a chance. We take him to the cath lab. He has 1% chance of survival. Please give us a permission. He said, no, I don't think so. But behind the screen, he called back his hometown, Warangal, and said, it's evening 4:30. Pick up the firewood for the funeral. Pick up the firewood for the funeral. After sunset, firewood is not sold for funerals. Spoke to the wife, he said, give us a chance. It takes about 2.5 lakhs. We'll attempt. We just do an angio, see if we can open the vessel. The wife reluctantly agreed for an angiogram. I said, I'm not going to do an angiogram. I need full permission for an angioplasty. Give me a permission. He said, okay. The wife said, talk to my son-in-law. Son-in-law says no. Wife says no. Ultimately, we said, okay, fine. Then a standby attender said, sir, if you want to think, please try. If you have 1% chance, please try. We took him to the cath lab, doing CPR, no balloon pump, no IABP. We just opened, went in with the wire, opened the vessel, circumflex opened, VTVF stopped, rhythm came back, survived. We don't know, we told the patient, hypoxia is one situation we have. We don't know how long he'll be hypoxic. 3 days later he opened his eyes, 4th day there was an eye contact, 7th day he was discharged. This happening from an orthopedic doctor's family. The denial, acceptance is very less. We need to take them into confidence. We need to bond with them. It's a short interaction for 5 to 10 minutes. You want the patient to have full confidence in you that you will save his life. It's difficult to get that in that 5 minutes, 10 minutes to get that full confidence. Extremely difficult. You need to bond with the family. You need to bond with the attenders and tell them, look, this is the only chance he's got. And that 5 minutes is very, very important. And we don't know the outcomes. There's a lot of ambiguity of the outcomes. I don't know, he would come out with an hypoxic.
I fully probably can think about there must be many failures along with this success, which
Absolutely.
can be possibility, a common phenomenon.
Yeah. So, and the doctor survived for 11 years, died in COVID with a COVID infection. 11 years is a good life.
Yes.
And the son denied his angioplasty for his father. And the call was for a funeral.
Rightly said. I think this is a negative part, but again, what I felt is because of COVID has given us quite a bit positive things also.
Because exposure.
Like, how much knowledge general person or people were having about ECMO? Live general people. How many of us were knowing about ECMO?
Absolutely.
Right, because I think I am involved in the ECMO part from 2013-14 onwards, because I was in one of the biggest cardiac unit over there in Narayana, Bangalore. That's why we were part of that. But I don't think as a vascular surgeon or as a other specialty, people were too much aware about ECMO. Second thing, what COVID has taught other people is it requires money, time. Third thing, patient can come out of ventilator and ECMO machine. They have given that hope also, that after 30 days, 35 days, 45 days of that, yes, patients can come out of ventilation, ECMO and all those things. I think, so some positives also we have gained because of COVID.
One example, second example. Again a doctor's father, admitted in Yashoda's Malakpet, had a very complex anatomy, post-bypass surgery, single surviving graft, critical lesion. I said, this patient cannot be handled at Malakpet. We would like to shift the patient to Secunderabad. The patient, who's a son, the patient's son is again a doctor, senior physician, doesn't have much knowledge, but practical, up-to-date knowledge. So he came, inquired and said, okay, yes, we can do this case. We would need a very high level approach, probably an ECMO, a ventilator, a rotablation, heavily calcified vessels, 2 or 3 stents. We may need something called as an impella. Impella is a
Yes,
device which
all of them are aware of it.
fantastic. So we said we may need an impella also. He said, fine, cost is not an issue. Cost is not an issue, please go ahead. I said, okay, when do you want us to ship the patient? He was stable at that time. We said, ship the patient at 4 in the morning, so that he's in traffic, he doesn't interrupt us this travel. Be here by 6 o'clock. By 6:37, we should go on the table. All agree. They came in by 8 o'clock. Admission process took another half an hour. 9 o'clock, patient went into pulmonary now. We called the patient and said, okay, now we're going to put him on a ventilator and going to take him to the cath lab. He's crashing, beginning to crash. We will put an IVP and if necessary an ECMO. Very well. 2 more attenders walk in, a gynecologist and ENT surgeon. Well wishers for the patient and the doctors. Neighbors, friendly neighbors. When it is said we're going to put a ventilator, do a rotablation. Rotablation is a device which we drill through the coronary arteries, remove the calcium and put a vessel there, stent there. Rotablation. No. This is the words of the gynecologist. The ENT surgeon says, ECMO. What's wrong with ECMO? ECMO. I mean, see, he's crashing. I may need an ECMO. I'm putting an IVP, but I may upgrade this on the table to an ECMO. The ENT surgeon said he has not heard the word ECMO. He has heard the word ECMO, but for his friendly neighbor, he said, no, I don't think we should go to that level of, and nobody comes out of ECMO. Nobody comes out of ECMO. Those are the words. And the son said, I can afford the sky. I am from US, I live in US, I know what I can do. But he said, Doc, my neighbors are telling me, I think they're advising me against. As we were discussing all this, the patient crashed, arrested, had a CPR. Now he comes in and says, okay, do everything. So the friendly neighbors, what doctors again, a gynecologist, and nothing against gynecologist, nothing against an ENT surgeon. But the friendly neighbors advise, the denial, not acceptance for the higher technology what we have, which is doing wonders with the outcomes. So you may not say 10 out of 10, but 2 out of 10 are going to see a good quality of life.
I think not seen, not believed. Let us even talk to ourselves. How many of you, maybe a few years back or a few months back, even now also, are in the belief that any of your family member is in the need of ECMO and you will think about the survival and recovery. So it's a difficult task for any of us, but what happened is even on a ventilator, for a layman or any families, now doctors has understood that. Whenever we put a ventilator, they say it is the end of it. So already all is gone, it's just a formality, this is what is continuing. Now, at least for a medical fraternity, we are slowly changing from that to a little ahead. The same thing is about ECMO. Like ECMO has been considered as an extreme step at the end of everything when we are at the dead end. And we as a clinicians, as you rightly said, sir, the learned clinicians also need to be aware of things, need to actually see to believe. Suppose if you ask me 10 years back, we will have the same question or the same thing in our mind. But when I see a 10-15 patients coming out well, if I know there is a reversibility cause, I start believing it. So we sometimes may not expect this from each and every clinician across the spectrum. So that will be a
I just
challenge.
wanted to mention this. When we had the first wave of fine, we had one irrigation engineer in Malakpet. That was the first ECMO we instituted and the patient successfully went out. That was the first time I saw ECMO machine in my life. Like, we know about CPB, heart lung machine, everything, but that's the first time. The next time is like basically the doctors who have so much of knowledge, they deny treatment. There are some patients who don't have knowledge at all. They are our hospital employees. They brought their uncles. One patient, I still remember, Shashikant sir and Rashekar sir bailed out him from Omni Hospital in ambulance with that Lucas machine. Patient came to our casualty. We took the patient into cath lab. We put in ECMO. Then we put an IABP. We put 4 stents. Patient went home. That's a positivity. Take it. Negatives come in a lot. And even what Venkat was telling about one gynecology patient, that was Vineet's call who gave me that day. He called me at 5 o'clock in the evening. Why don't you come and see this patient? She's a 26-year young female with stress cardiomyopathy with a pH of 7.1, 20 ml adrenaline, 20 ml NORAD, 20 ml dopamine. That's it. no urine output since last 15
So
minutes.
in the limit of time, we will try to confine, otherwise, sir, please quick comment.
Yeah,
You can just comment and
yeah,
comment.
the first ECMO for a patient with needing a post-operative support with an ECMO. A patient had an aortic valve replacement, severe LV dysfunction, was not surviving. Dr. Gokhale and team did a first ECMO in the south of India, in Hyderabad, in Yashoda Hospitals.
When was that, sir?
2006, no? 7 or 8, I think.
Okay, I think we will take Dr. Oja sir's experience of the first initial ECMOs and his experience about how it evolved.
Now I feel the things is at least 100 times better than what it was when it was in 2006 and 2007 when we started. I remember still the first out of my hospital ECMO call I got from Hyderabad, from a global away. And at that time the call, how I get it, was some senior physician in Bombay were known to the people in the patient relatives in the Hyderabad. So they called up and they asked, do you have ECMO machine in Bombay? He called me up and said, okay, do you have ECMO machine? I said, yeah. So can you send it to Hyderabad? I said, sending the machine is not going to be enough. I have to go with the team. So that was the time, that was the first case which I got a referral. And that referral was from a family, because it was an H1N1 and the family is known to someone in the US and they advised. And intensivists and physicians were not very much.
They're taking a neutral
Yeah,
role.
they were not taking neutral. They said it's an experimental science and if you want to go ahead, you can go ahead with that. The second, that patient he was in a shock state and she survived for 48 hours and then she had IC bleed and she didn't survive. After a few days, just from the same hospital, I got another call and that patient remains on ECMO for 30 days and almost after 15-20 days, the hospital authority was just behind me that you call it off now because there is no chance, the expenses is going up. You are from Bombay, you will go up and our hospital reputations and everything is going to be at stake. But the family were quite confident and they wanted that care to be continued. And then luckily he came out after 30 days of ECMO. So that was the story at that time. If you ask me what
Evolved over the
evolved,
time.
yeah. The thing slowly started improving probably in 2014-15 when another episode of H1N1, the more and more centers started getting involved. And then probably in COVID, I think the scenario has completely changed. And the number of centers has increased and even the people, public education has also started coming up. So that time I used to get a call, even before putting the patient on ventilator, people wanted to go for an ECMO. So that was a story where people used to call me up for, said that no, this patient requires high flow oxygen, he is on HFNC, 60 liters and 100% FI2, so rather than going on ventilator, we know 100% mortality, so put the patient on ECMO. So that is where the things land. Now what I feel is what we need to do to sort out all this, number one is to improve the awareness in the amongst our colleagues. That's the most important thing. May not be from the intensive care branch, but from other branches also, because people tend to go more towards them, even the GP. We need to do a lot of level of education at the level of GPs. Second thing, as far as ECPR is concerned, I really feel that it's going to be a very difficult task if it's not non-patient or patient is not in the hospital for some time. Then it's going to be
It's
difficult.
going to take a little time.
Yeah, that is going to take some
In
time.
hospital, a witnessed arrest is
Yes.
not possible.
Yeah, that is more, because you know the family, you know that whether they can afford or no, so that becomes the third thing is good you got an admin people in the bench
So
here.
we felt the first selection was from an admin. Unfortunately, I think we wanted the other admin also. He escaped us. So
Yeah, so I have one suggestion for.
they are the head of the unit. So
They
they
always,
they take
we call
the
in first 5 minutes itself.
Yeah,
So that-
I have a suggestion for you people to just think about it. Okay, as we have a different class for just all procedures for CABG, yes, you can get admitted in general class or to a suite class, and you have different rates. Why can't we do the same for ECMO to promote it? if you have more number of patients, okay, you will learn by the volumes rather than from one patient. So I think that needs to be considered, that idea. And for that also, even ECPR, we can get the cost of ECPR little now. Suppose you don't know, patient might feel that he might you feel that admin people feel that no, at least 1 or 2 lakhs income. You can always start ECPR with your simple oximeter what we use for the bypass that costs you around 20,000, and you can have a second-hand machine like a Medtronic machine where the pump is hardly 10,000, 20,000. You can think about that using that. The cost of even starting ECMO is not going to be more than 50,000. And in that case, suppose patient survives for 6 hours.
Then we can switch off.
Then you can switch over to proper ECMO machine. And by the time you can have a time that you can assess the relatives and.
One is a provisional or a temporary set of extracorporeal switching to a longer.
Yes.
So I think
Actually, we have been doing this in cath labs. Actually, we used to take the heart lung machine circuit, a cone and normal oxygenator.
Yes, that is what is
So we have done aggressive stenting for most of the LFCAs where they want only 60% support for cardiac output. We are done, and after 6 hours, 8 hours, in case still the patient needs, you can go back to the
the question, Ravikant, is why can't we do it for emergency cases and also cardiac cases?
I will take this question, sir. Sir, Jay sir, I am happy to announce here. So we are grateful to our promoters and especially second generation directors. We are all empowered, sir. Within, if I get, as you mentioned, 1 a.m., 2 a.m. call, I can take decision for if I get a call from emergency. Only irrespective of the finance, sir, if patient is a salvageable case per age and breadwinner of the family, irrespective of the finance, I am empowered to take this decision. We will go take.
So we are keeping a buffer fund or a buffer kind of thing. We are planning that, sir, as you suggested. To just continue this, I think Dr. Preeti and Dr. Harikrishan, what they were used to do is a patient where the airway has been completely involved and they need to handle the airway. Sometimes they have to play with the airway, they can't have any ventilation at any time, and some of the patients crashed when they were doing the procedures. And in many of those situations, this kind of rescue came. And initially it was an experiment to start with, but now it became a new norm. They counsel the family in advance, they keep that as a standby. So what is that concept which you are evolving? I think this is like HFNC for intubation, as I said. NIV for any bronchoscopy, as I said, they keep ECMO as a standby to do their procedures safely. So what is that you evolved over time?
Sir, initially all these big tumors and stenosis, very small tracheal lumen, these cases we used to do it as a high risk case. We have to take the patient under deep sedation. We have to paralyze the patient, which will lead to more airway compromise. Most of the procedures we do will be under rigid bronchoscopy. Along with that, we use electrocautery instruments where the FiO2 should be less than 40. That is very difficult when the patient is requiring such high FiO2. So initially, like you said, it was a learning curve. So the first patient was 11-year-old, we did EBUS, and the patient was okay. Later, difficult to ventilate, diffuse airway edema. We have given hydrocort, magnesium, bronchodilators, everything, but the patient is not coming out of anesthesia. So that point of time when we did ABG, 6.9 is the pH. If we had continued, she would have arrested or stable. That point of time, we didn't know what to do next. So we called in for the ECMO team. First experience was with a heart-lung machine. We put the patient on heart-lung machine. 3 hours later, decannulated, she was fine. Next day, she went home, huge scar on the sternum, but at least we saved that patient, otherwise she would have arrested.
So it is like a central switching to a heart-lung machine.
Actually, that patient had a lot of financial constraints, so immediately I shifted the ECMO, the heart-lung machine down. We put it on CPV circuit and we salvaged.
Sternotomy, central CPV circuit.
Within 3 hours, we decannulated her.
Okay, what we done is we put a femoral cannula between the sternotomy and they put aortic cannula. Meantime, we put already femoral cannula. She went to CPV.
To be very honest, for 4 to 6 hours procedure, you don't require ECMO circuit at all.
The same thing, sir. That is one area where we were not sure about the family. We are not sure about what is going to be happening.
That's why
I think we can bridge that.
All the airway procedures, I think we now right now streamlined how to go because we don't have space in the neck area at the time of real.
So we will take
Our first encounter when we met.
yes, Continental. It was
the
see, we didn't had an ECMO at that time when I was in Continental, and one of our foreign national patients suddenly had a crash and not reviving out of CPR. After a lot of struggle, we could actually achieve the rhythm. It was in 2013 or something, and at that point of time, when we were actually putting the IABP, nothing helping, so we wanted a ECMO to be initiated. ECMO machine was not available, it has to come all the way from Mumbai at that time. And in the bridge, we just brought the same thing. He was undergone a CABG on pump. The same CABG, the same on pump has been reinitiated in my ICU. So sternotomy wires were opened, recannulated back, switched to a cardiopulmonary pump, continued that for 6 hours. They took time because it is all another 5-6 hours more. So the oxygenator was changed for the temporary time being, and by the time they reached and switched to a proper ECMO, and that's the first experience even we had. So coming to switching to the surgeon, sir, Dr. Balasubramanian sir, you have been a part of surgical team, thoracic, vascular and all. So what will be a futuristic role as a thoracic surgeon and dealing with this airway, as ma'am said, and you must be also dealing a lot of airway cases and the complex high risk groups, and your role in also creating, you are talking about a graph today. I was just discussing or learning from you when Dr. Misra was mentioning they had an experience of safer distal cannulation and all. What will be your role as a surgeon?
Yeah, so see, basically ECMO has been in a game changer in our specialty. See, mainly we deal with renal tumors or if you are doing complex airway work. So there we have to coordinate the anesthesiologist to keep ventilating. You have your cross-field ventilation. We remove the endotracheal tube. We do a few stitches. Then the saturation is dropping. Then we have to put it back. So a lot of coordination used to happen. We had occasional complex scenarios where we are not able to ventilate at all. So once you have, these are the situations where we advise them to go on ECMO. So then we don't have to worry about your desaturation or ventilation.
What is the risk of bleeding in them? They are anticoagulated, you are handling an airway and a very...
So the whole advantage of having ECMO compared to a CPP. CPP you require around 3 to 4 mg per kg of heparin. Here
so that's the advantage.
Here you have only 1 mg per kg. Okay. So we are not concerned about bleeding at all. And if you have a L-Saver 2 on, you don't lose blood either. So two is you have huge mediastinal tumors where the whole airway is remaining open because of the sympathetic drive only. So once they go on to anesthesia, the airway can be lost. There is no role for a tracheostomy here because the whole tumor is here. You cannot do a tracheostomy. There also the ECMO has a role. So third would be of course lung transplants. Where preoperatively we have an excessive of ILD, you are on ventilator, now not able to ventilate, PCL is going up. We use a ECMO as a bridge to transplant. Although having said that, we make sure they are willing for a lung transplant, or it becomes a bridge to nowhere. So that's pretty important. Fourth, post transplant or in the transplant we use VA ECMO as a strategy. Really brings down our stress levels because you are not worried about desaturation, hemodynamic compromise, and when you restart reperfusion of your lung, you are able to control your flows. So it really brings your PGD rates lower. So there are studies now where people report 1.3% graft dysfunction, and compared to around 30% earlier, only because VA ECMO is.
So we are learning more and more beyond the conventional indication for thoracic surgeries. Just because of the time, we will actually giving a last penultimate question to Bhavin Ram sir, and then there are questions which all of us wanted to hear the answer. We will take from Dr. Vivek Gupta. So the question to Bhavin is, recently we have seen the invasiveness which we used to do for any VA ECMO, you drastically dropped it to bottom low. You have to see his procedures to believe. You will just have two guide wires, two just cuts, and it will make a center line plasters. So what is the changes? Is it possible in all, or do you also face the problems in a patient with a lot of obesity and when the vessels are intricate? Because Dr. Vivek Gupta was also mentioning it is wise to actually have a visible vessel and then puncture and dilate.
So, Dr. Venkat, as I was telling you, my earlier experience was from 13, 14 onwards. Why? Because 14, I remember that was a patient who was known to me also. Young patient, 34-year-old, came with a respiratory problem. I don't know what reason it was, because I am particularly a surgeon. I don't know about all this. So he required a arterial ECMO. So at that time, left femoral vein, right femoral artery was cannulated. Okay. After 3 days, we found out that he was having a turgid and very tender cough with gangrenous changes in the foot. Probably what happened, we are putting 17 or 18 French cannula in the femoral artery, which is around 6 mm in the diameter. So you are obstructing full arterial circulation. Distally, nothing is going. He had acute limb ischemia of right lower limb. Unfortunately, it was late when it was picked up. He landed with above knee amputation. And I know that gentleman very well, 34 at that time, and now he is fine, but he is having prosthetic limb. Right, and this was a time when we used to do open groin procedures. We open the groin, we put the cannula, 16 French, 18 French, not an issue. What evolved over time, we are now endovascular surgeons. We are not just vascular surgeons. We do aortic aneurysm, as Shashikant sir can say, endovascular, totally percutaneous procedure. We don't open the groin nowadays to correct the aortic aneurysms also. Those devices are 24 French, 26 French also, sometimes large aneurysm you have to do, and that can be done through the femoral artery only. So now that time is gone where you have to see the vessel to cannulate. You ask any endovascular surgeon, anything we do percutaneous using the ultrasound. Now what other thing we do is, we learn from an experience, I think all the ECMO big departments are doing that. One big cannula goes towards the aorta, other you have to perfuse the limb. So we put a four
What is
small...
the gap you maintain?
So again, it's the difficult
I have
part.
seen one guide wire goes retrograde, one goes antegrade.
Yes.
And what is the gap you maintain? Inguinal canal, inguinal ligament up and down.
No, you always have to be below the inguinal ligament.
Okay.
You should not
What
be
is the
going
gap?
So again, what happens? You have to be knowing about the anatomy. You are puncturing common femoral artery only. If you are puncturing SFA or something, you are asking for disaster, and that distance is always from 1.5 to 3 centimeter. In a 3 centimeter distance, you have to put a one cannula towards upside, other cannula towards downside. Unfortunately,
So which you cannulate first when you have two guide wires?
So I always prefer to go down first, because that is the important part. That is a small cannula. So I puncture the either SFA origin or at the CFA, and cannula is directing towards the lower down. Keep the wire, don't put the cannula, because once you put a cannula, you are not in space. Yes, put the just guide wire. And then at the same time, you puncture the CFA retrograde also towards that side, and put a major cannula first, because otherwise you will not have space. One big cannula.
That's what I wanted to know. First you put the femoral artery cannula.
SFA one, that first, then guide wire and all those things, the higher up cannula. Unfortunately, what I wanted to do was that removal of this cannulas also should be percutaneous, because in the aortic aneurysm we use a vessel closer device. You do not have to open the groin, but because you are doing percutaneously, you will be having at least 1 centimeter
rent
zone. No, rent you can close it off with the closer devices. So you are not worried. But one cannula towards upside, other is downside. In between, remaining 1 centimeter zone is there where clot forms, because you are
not perfusing that area.
That area is left behind, because initially I thought, okay, I will use the closed device. But when we opened up the vessels, we always found small clot lying down over there. And that's why, unfortunately, I think you have to be that much precisely good enough that 1 centimeter dead space also not remaining. Then you can use the totally perclosed device. Otherwise, yes, cannulation we are doing percutaneously, but removal is open.
So, just in the interest of time, the last question in which we all wanted to know. Everything is fair and good, but all of us has the cost. And in India, everything happens like jugaad. We make jugads, okay? We were talking about the same jugad. You will not find this some kind of jugads in anywhere in the world. Like you use oxygenator, you use pediatric circuits or perfusion to take out your CO2 and all. So we are fortunate to have Dr. Vivek Gupta here, who works in a trust hospital and deals with some of the middle class and lower middle class families also who cannot afford a proper ECMO, creates his own circuits, handles it well, and has been successfully doing it with his own ways. So we wanted to learn what will be the future of that drug. And he deals with a lot of intoxication which is on none of the indications. See, aluminum phosphide, paraquat. I have been seeing some of his case series on paraquat, aluminum phosphide, and many of these terminally sick patients has been handled by you. So what is your take on that?
So as far as cost is concerned, this is a big concern, as everybody is rightly saying, because it's not only initiation cost, it's a maintenance cost as well. You don't know, especially when we talk about VA ECMO, you know that probably it will end by 6 days, 7 days, 8 days, not probably more than that. But for VV ECMO, you don't have. So when we started ECMO, it was a big challenge because as everybody is saying, nobody was knowing ECMO. So when I talked about ECMO in 2013, so it was a big issue that how the cost will come from where machine and all. So there was a centrifugal pump which was lying in the cupboard. Taken in 2001 and 2012, surgeons were planning that we will condemn it and relieve this pump from the OT complex. I said, give it to me. So it was only a SANS pump, and I was fortunate that hospital gave me one more monitor to connect it with this SANS pump to make it a ECMO machine. This is how I learned from Oja sir. And then the question was now circuit. So fortunately there were a lot of holes were there, probably which had come along with the machine. So I found out that what next to be done. So oxygenator, at that time, fortunately, BL Life Sciences had these 6,000 these oxygenators. So we negotiated Yamida's oxygenator. So we negotiated and finally they said 42,000 rupees oxygenator. So I calculated the cost of pump head, it was 7,000 rupees. And tubings and connectors, it was say 1,500 or 1,200 rupees. So we were able to make a circuit in the 54,000 rupees in the beginning. Then I talked to the hospital. I was fortunate enough that hospital supported. Fine, we will not charge any extra money for this. Whatever is their cost, we'll take that. We got it ETO. And then this was the first thing we started for aluminum phosphide. We were fortunate that the first case, hospital didn't charge anything extra, only the cost to cost. And it run was almost for 4 days, and fortunately that was survived. So the hardly any cost, and that started this concept that we can do ECMO at a cheaper price. Then we started exploring other things, keep discussing with Oja sir and Venkat sir that how to go. Then we started reducing the number of tests, investigations, whatever is required, more focus on the clinical aspect rather than just ordering blood gases hourly or 2 hourly. Probably we do twice a day, or even after 10 days of ECMO, once a day. ABGs are more than enough. Probably sometimes I say don't do ABG, it's fine, patient is doing fine, don't do anything. So these things have been tailored, and so we are able to cross the number of 200 in last 10 years, and now it's the 10th year. So this is how we are doing. But yes, company people are very smart enough. Now they have the customized circuit and they don't provide the separate pumps or separate oxygenators. So we are again trying, though after COVID the cost has increased, but still we are able to do the ECMO at a pretty cheaper price.
They are still providing the pump.
They are not selling the
Pump separately.
oxygenator separately, but they are ready to sell the pump separately, provided you make the condition at the time of purchasing the machine that you will sell the pump separately to us. That is most important. You have a lot of oxygenators available from other companies, and they are all are PMP oxygenators. So not a huge difference between the quality of the oxygenators. So you can use the same the pump of the machine and any of the oxygenators, and that brings down. Even if you consider the same cost from the same company, the pump cost you 20,000, the oxygenator cost you, it was initially 35 when we started, but then it is now around 85,000 or so plus CST. So that will be somewhere around, even the cost of the circuit, even if you make it right now, will be not more than 120. Okay. And the same cost they charge 210, or more than that, and then the hospital charge gets added up into that. Yeah. So I think making your own circuit makes you the cost. And
So now as a society, as a senior clinicians members, we should actually talk about this, as you say, the volume gain. If that could be dropped down, like any other equipments or gadgets, if the number has been increasing slowly, if we drop the cost, so I think that volume gain will should be giving them back. So this is a high time that all the leaders in the field should talk to the different industries which are actually creating them at a cost-effective model, something made in India with the same quality.
We are just working on that.
So that will be great. So when there is a will, there is a way. That's what has been proven by many of you. So we should give them a big hand of applause for that.